Today's class is on approach to a patient with vasculitis. So first we have to see about the classification of various types of vasculitis. So here we can see. We can classify vasculitis into either single organ small vessel vasculitis, or we can also classify based on CHCC classification as well. So CHCC classification is nothing but Chapel-Hill consensus criteria classification, and based on that we have three different types of vasculitis. One is small vessel vasculitis involving a single organ, that is cutaneous small vessel vasculitis, urticarial vasculitis, which excludes immune complex disease, and erythema elevatum diutinum, acute hemorrhagic edema of infancy, recurrent cutaneous necrotizing eosinophilic vasculitis, and granuloma faciale. Immune complex mediated vasculitis include IgA vasculitis, cryoglobulinic vasculitis, hypocomplementemic urticarial vasculitis, that is HUV, antiglomerular basement membrane vasculitis. Then other than that, there is also ANCA-associated vasculitis such as microscopic polyangiitis, granulomatosis with polyangiitis, that is Wegener's granulomatosis, eosinophilic granulomatosis with polyangiitis, that is Church-Strauss syndrome. The terms Wegener's and Church-Strauss syndrome are not commonly used now. Instead, we are going to use the recommended nomenclature, that is granulomatosis with polyangiitis for Wegener's and eosinophilic granulomatosis with polyangiitis for Church-Strauss syndrome. Among the medium vessel vasculitis, we have polyarteritis nodosa, which includes cutaneous polyarteritis nodosa and Kawasaki disease. Among the large vessel vasculitis, we have giant cell arteritis and Takayasu arteritis. So we can see here the cutaneous vasculitis having a system disease or variable vessels. That means they can involve all sizes of vessels. That means we can't really predict which particular size vessels, whether it is small or medium. We can't really predict. They might involve all at a time. So those diseases are lupus vasculitis, Behçet syndrome, sarcoid vasculitis, and rheumatoid vasculitis. So first, in order to approach a patient with having vasculitis, in order to this thing, if at all, first of all, if we want to suspect vasculitis, what are all the things we should consider? One thing is the cutaneous lesions, which are very important in case of vasculitis. So the cutaneous lesions, such as palpable purpura, urticaria, erythema, vesicular-bullous lesions, ulcers, whether it may be superficial or deep, splinter hemorrhages, subcutaneous nodules, livido reticularis, pitted palmar or digital scars, digital gangrene or Raynaud's phenomenon, infarcts, erythematous nodules, gingival hypertrophy, oral genital ulcers, and if there is any known history of connective tissue diseases, we should always suspect a case of vasculitis. So these are the palpable purpura. Here we can see this is the diagnostic test which is being done here. So if it is an erythema, if it is just an erythema, it will blanch on doing diagnostic test. In case of the palpable purpura, won't blanch because there is extravasation of RBCs into the interstitial space. So the RBCs are not exactly present inside the vessel, so there is no point of this thing blanching seen here. So if blanching is not seen, this is a simple test. Whenever you have a doubt whether it is a simple erythema or it is a whether it is a purpura, you can do a diagnostic test where you press a glass slide over the particular area affected, and if there is blanching seen here, then you can consider it as an erythema. If there is no blanching, if the lesion stays the same, then you can consider it as a purpura. So here we can see urticarial vasculitis generally presents with lesions which are very similar to urticaria, that is the veins. So erythematous wheals can be seen here. So one important thing how to differentiate between urticaria and urticarial vasculitis is urticarial vasculitis, the lesions will stay much longer time. That is, they will last more than 24 hours. Whereas in case of urticaria, simple urticaria, generally the lesions will disappear. They will be very transient. They will disappear in 1 to 2 hours. Now most of the time they will resolve within 24 hours. So that is one big clue. And apart from that, urticarial vasculitis will also have pain. And urticaria, just urticaria won't have pain. Instead, it will have itching. So these are the vesicular-bullous lesions, which can be seen. Some are purpuric here. We can see. 1 second. Yes, sir. Here we can see vesicular-bullous lesions. Here we can see vesicular-bullous lesions. There are some purpura as well over here. So whenever you see such lesion, you should always think of vasculitis in addition to other vesicular-bullous lesions. Other manifestation, one other important manifestation, cutaneous manifestation of vasculitis includes subcutaneous nodules. Here we can see there is erythematous subcutaneous nodules. Most of the time they will be tender. This is the picture depicting a case of libido reticularis. Again, it can be a manifestation of vasculitis. Here we can see in this picture, we can see multiple pitted scars at the tips of the digit. So again, it can be a manifestation of vasculitis. And here we can see the digital gangrene, which again can be a manifestation of vasculitis. And here we can see splinter hemorrhages, which can be a manifestation of vasculitis. So these are the, we already saw the important cutaneous manifestations, which are going to basically, which can cause, basically when to suspect vasculitis we have seen, based on seeing the various cutaneous manifestations. But the one important thing about vasculitis is it's not a single system disease. It's a it can be a single system disease involving only skin, but there is always that part where it can involve multiple systems in addition to skin as well. So multi-system involvement, for example, involvement of kidney, involvement of lungs, or upper sinuses. So based on or even involvement of nerves. So all these things, which are like, or even bowel involvement, all these things should be considered whenever you are dealing with a case of vasculitis. And apart from that, there is if there is unexplained fever and weight loss, we should suspect vasculitis in those cases as well. And unexplained ESR or CRP with elevated CRP and ESR again can be due to vasculitis. And any occlusive arterial disease or hypertension in case of the young adults, obviously you should think of vasculitis as a cause, since hypertension is mostly seen in older patients rather than in the young population. And apart from that, if at all, if there are any cardiovascular events such as myocardial infarction or gangrene or any cerebrovascular involvement such as transient ischemic attacks or strokes in young, so these also will point out to something wrong with the vascular system. And any unexplained proteinuria with or without CAS also should point out to the vasculitis. You should always keep a diagnosis of vasculitis in suspicion. And any sudden retinal vascular disease, for example, the patient develops episcleritis or uveitis all of a sudden without any other comorbidities such as hypertension or diabetes. Again, so you should keep a suspicion of vasculitis. And sudden appearance of peripheral neuropathy. For example, patient was normal and suddenly he'll develop wrist drop or foot drop without any other thing, without any other causes. So this can be nothing but mononeuritis multiplex, which can be again a manifestation of vasculitis. And any unexplained finding of pulmonary nodular or cavitated lesions or any persistent headache with sudden visual impairment, monocular blindness in the elderly, you should always keep vasculitis also as a differential. And any jaw claudication which is seen in the patient, so we should always keep vasculitis as a differential. So in order to suspect ANCA, when do we suspect ANCA associated vasculitis? So as we already saw that ANCA associated vasculitis include Wegener's Church-Strauss syndrome, right? So these are the things, and microscopic polyarthritis. So when do you suspect a case of ANCA associated vasculitis? Main thing is it is a quasi-immune complex mediated this thing. The immune complex deposition won't be very obvious like in other immune complex mediated this thing. It will be quasi-immune. So when to suspect these kind of things, one thing is if there is asthma, especially late onset asthma, if there is nasal polyps and hypereosinophilia, we can consider a differential of Church-Strauss syndrome. Multiple lung nodules, chronic destructive disease of upper airways, long-standing sinusitis or otitis, subglottic tracheal stenosis, mononeuritis multiplex or other peripheral neuropathy, retroorbital mass, scleritis. You should always keep Wegener's in mind. Step 2 is to rule out. Step 1 was to, based on the clinical picture, to suspect vasculitis. Step 2 is to rule out diseases that can mimic vasculitis. So the common diseases which can mimic vasculitis include any vessel wall incompetence or pathology, infections, then malignancies, any thrombotic and embolic disorders, and even sometimes drugs can mimic vasculitis. So we should keep a suspicion of them. So common things include, for example, here due to hemorrhage, there can be purpura developed over there. So that can be due to multiple causes. For example, solar purpura, pigmented purpuric dermatitis, scurvy, idiopathic thrombocytopenic purpura, and some viral disorders, arthropod or insect bite reactions. Then drugs, all these things can lead to purpura-like manifestation. Some infections, for example, infective endocarditis, again can present with splinter hemorrhages. So it's a common thing we should always rule down. Then septic vasculitis. So patient with sepsis can have septic vasculopathy or septic vasculitis. So that we should always think of. Then Lucius phenomena. So due to leprosy, endothelial swelling, which is caused due to leprosy. So these are the various infective causes which can mimic vasculitis. Then among the embolism, it can be the cholesterol embolus or atrial myxoma. So these things also we should keep in mind. And among the thrombotic disorders, it can be APLA, then thrombotic thrombocytopenic purpura, and livedoid vasculopathy. We should always keep in mind. These will be differentials for vasculitis. And other than that, the antiphospholipid antibody syndrome, thrombotic thrombocytopenic purpura, which can be seen in SLE patients, lividovasculopathy, warfarin-induced necrosis, purpura fibrosis, TIC, monoclonal gammopathy, that is primary cryoglobuline-induced monoclonal gammopathy, and sickle cell disease can also result in thrombosis, and these can mimic vasculitis. And drug-induced causes such as ergot derivatives, methyl saccharide, and cocaine can cause vasospasm, leading to vasculitis-like presentation. Some trauma such as hypothermia Hammer syndrome, and some vessel wall pathology such as calciphylaxis, amyloidosis, and radiation arteriopathy can also mimic vasculitis. So one important thing which they will ask in the exam is what are the drugs which can cause vasculitis. So one thing is cocaine is a very important thing. Then apart from that, phenytoin, the sulfur drugs, penicillins, hydralazine, allopurinol, propylthiouracil, and thiazides. All these things can cause vasculitis. So it's very important. Step 3 is to look for the pattern of vessel involvement. mainly whether it's a large vessel, vascularitis, whether it's a medium vessel vascularitis, or whether it's a small vessel vascularitis. We should always like try to assess the pattern of revolving. So because why? Because based on that we can know the proper probable diagnosis, like I told in the chapter classification. So large vessel involvement means either it will be tachysus arteritis or giant cell arteritis. Medium vessel means either it will be polyarteritis nodosa or Kawasaki disease. In case of small vessel vasculitis, if it is immune complex mediated, it can be cryoglobulinic vasculitis, IgA vasculitis, hypocomplementary urticarial vasculitis. In case of ANCA-associated small vessel vasculitis, it can be microscopic polyangiitis, granulomatous with polyangiitis, and eosinophilic granulomatous with polyangiitis. So commonly, based on the clinical manifestations or cutaneous manifestations itself, we will be able to make out whether the involved vessel is a small vessel or a medium vessel or a large vessel. So one thing is in small vessel vasculitis, the common the blood vessels involved is post capillary venules. The blood vessel involved is cutaneous post capillary venules. It will manifest as palpable purpura. If there is a like the glomerular capillaries are affected, it will manifest itself as hematuria, red cell parts, proteinuria, and decline in renal function. If it is pulmonary capillaries which are affected, it can cause lung hemorrhage as a which manifests as breathlessness, hemoptysis, and widespread alveolar shadowing or chest alveolar. If it is medium vessels which are affected, so if it is the cutaneous arteries which are affected here, so then it can present with necrotic lesions, ulcers, nail fold infarcts, and mononeuritis multiplex. If at all nerves are affected, then it will lead to mononeuritis. Neural arteries are affected, it will lead to mononeuritis multiplex. If it is the mesenteric artery which is affected, it can lead to abdominal pain, gastrointestinal bleeding, and perforation because of the gut infection. If it is affecting the celiac artery, then it can lead to infarction of spleen, liver, and pancreas. If it is renal artery, it can lead to renal infarction. If it is coronary artery, it can lead to myocardial infarction, angina, coronary artery aneurysm, ischemic cardiomyopathy. If it is small pulmonary arteries which are affected, it can lead to necrotic lesions, leading to cavitating lung shadows on chest X-ray. And small arteries in the ear, nose, and throat region can lead to nasal crusting, epistaxis, sinusitis, deafness, stridor. So these are the various manifestations due to medium vessel vasculitis. We can see the various manifestations of large vessel vasculitis. So the main thing is here, large vessels are nothing but aorta and its branches. So if it is extracranial branches of carotid artery, they will develop with temporal headache, temporal arteritis or giant cell arteritis, right? So temporal headache, blindness in case of ophthalmic artery is affected, jaw claudication if the vessels supplying muscles of mastication are affected. If it is thoracic aorta and its branches, it can lead to limb claudication, absent pulses, unequal blood pressure, TOEs, thoracic aortic aneurysms. So next step in the approach to a case is step 4. Step 4 is nothing but you will confirm the vasculitis and you will assess the extent of vasculitis. So how do you confirm the diagnosis? You will confirm the diagnosis by doing a biopsy and an immunofluorescence study. So deep punch or incisional biopsy extending to subcutaneous should be taken from the most recent lesion or most tender lesion, reddish or purpuric lesional skin. So most recent reddish or purpuric lesional skin, or if the patient doesn't know the most recent one, you can take the most tender reddish or purpuric. And proximal lesions are preferred than the distal lesions, just to remove the effects of stasis And apart from that, the optimal time for skin biopsy is less than 48 hours after the appearance of vascular lesion. Main reason is there will be changes which might not be seen, like the changes of the typical changes of vasculitis might not be seen if we take biopsy after on a late lesion, both in biopsy as well as the DNA. Here we can see the various this thing infiltrate. We can see here anatomical purpura or cutaneous cytoplastic vasculitis. We can see that the affected vessels are predominantly small vessel. So in case of polyarteritis nodosa giant cell artery, it's towards the this thing. So you have to take the depth involved should also be more. Should involve the subcutaneous tissue as well. Even for ANCA-associated and even connective tissue disease associated vasculitis also should extend the biopsy up to subcutaneous just to see the infiltrates properly. Libido racemosa is basically presents with a net-like erythema, and we should take a deep biopsy here, and it should include subcutaneous as well from the white center and not the red periphery. So because the white center is where the thrombus is located, right? So stenoid vessel is responsible for the cyanotic periphery. So basically, in center is where the clot is located. So you have to take the biopsy from the center here, not from the periphery. And in case of vasculitic ulcer, generally non-ulcerated sites are preferred for biopsies. If not possible, from the edge of a superficial ulcer involving the rim of inflammation, we can take. Deep ulcers should be taken. Deep ulcers, biopsy of the subcutaneous area, including the central ulcerated area, we should take. And atrophy blanche lesion also we should take from the center of the porcine white scar. Is coming for the histopathology in case of coming for the histopathology in case of leukocytoplastic vasculitis, the purpuric lesions you should take within 24 hours, and you will be able to see fibrin deposits within the vessel wall accompanied by neutrophilic infiltration of the wall, surrounding hemorrhage with RBC extravasation or fibrinoid necrosis, nuclear dusting, or leukocytoplastia. After 24 hours, neutrophils begin to be replaced by lymphocytes and macrophages, and biopsy of lesions more than 48 hours old, regardless of the underlying form of vasculitis, may show lymphocyte-rich infiltrates. So this is nothing but angiocentric infiltrate with predominant neutrophilic this thing. You can see nuclear dusting as well. Then apart from that, fibrin necrosis, which is reddish. Extravascular granulomatous vasculitis or systemic vasculitis. So, we should always keep in this in mind. And lymphocytoplastic vasculitis, secondary to connective tissue disease, then viral infection, drugs, plevum, perniosis, we should keep in mind. And if it is small and medium vessel involvement, small and medium vessel involvement, you should keep ANCAs and also connective tissue disease induced vasculitis. And if there is minimal leukocytoplasia with dermal interstitial neutrophilic infiltrate, we can consider arterial vasculitis. So ANCA vasculitis, here is the picture showing. What are the mimics of vasculitis? Basically, the changes of vasculitis are frequently encountered in biopsies taken from ulcers, that is incidental vasculitis. In contrast to authentic vasculitis, the changes are confined to the vicinity of the ulcer and not seen through the tissue. Extravasated RBCs, that is several acute conditions such as pityriasis rosea, pleva, lymphadenopathy purpura, pettate psoriasis, and drug eruptions. They are not accompanied by changes in the vessel walls. There are several vaso-occlusive conditions which can actually mimic vasculitis. They will have a thrombus in the vessel without any inflammation. For example, this is the case of liver vasculitis. So DIF, if there is presence of predominantly IgA, which is suspect non-shown purpura, IgA, which is non-specific IgA, it is also like can be seen in SLE, endocarditis, dermatitis, herpetiformis, alcoholism, IgA nephropathy, IBD, ankylosing spondylitis, rheumatoid arthritis, and various other drug hypersensitivity reactions as well. So we can also demonstrate IgG and C3 deposits. So granular deposits of IgA, granular deposits of IgA in dermal vessels in non-shown purpura. Prominent IgM, if it is only IgM, then it will lead to cryoglobulin or rheumatoid vasculitis. And positive around the vessels and basement membrane zone is nothing but hypercomplementary urticarial vasculitis. We should always consider SLE. And negative include paucine vasculitis, that is ankylosing vasculitis. So this is the suspected chronic vasculitis of those with possible systemic involvement. We should always consider doing this CBC with the differential count, blood urea nitrogen or creatinine, ESR or CRP, liver function panel, urine analysis, stool wire test, and HPV or HCV serology. In order to identify the specific type of vasculitis, this is ANCA, whether it is P ANCA or C ANCA, we should this thing is that consider doing an ANCA to C ANCA or P ANCA based on the clinical manifestation. Cryoglobulin test, complement levels, eosinophilic counts or IgA levels, specific findings on biopsy such as necrotizing lymphatitis inflammation, presence of IgA deposits, evidence of immune complex formation or its absence, we should always consider. In order to assess the extent of vasculitis, we can always look for the systemic investigation, chest X-ray, CT chest and sciences, electromyogram, nerve conduction studies, echocardiogram or electrocardiogram, biopsy of the respiratory tract, upper or lower respiratory tract, biopsy of nerve, kidney or muscle, classic polyarteritis nodosa, mesenteric renal or celiac angiogram, consider biopsy of muscle, nerve, kidney or testicles. So in order to exclude vasculitis, which is known like mimics and secondary causes, we can always get a blood culture done, echocardiogram done, hepatitis B and C screening, HIV test we can do, anti-globular membrane basement membrane antibody we can do, antiphospholipid antibodies we can do, rheumatoid factor we can do, and ANA and ANA blood we can do. So in order to we should conduct some mandatory to perform infection screening. If at all, if they have systemic inflammatory features, we should always perform an infection screen, mainly because even septic sepsis can present like vasculitis. Procalcitonin levels are raised in patients with infection, but not in those with non-infective inflammatory conditions. So procalcitonin levels is one important thing which can provide an idea whether it's an infection. So general diagnostic approaches, there are 5 important questions to ask when faced with the patient with possible vasculitis depending on the clinical presentation. Is this a condition that could mimic the presentation of vasculitis? Is there a secondary underlying cause? What is the extent of vasculitis? How do you confirm the diagnosis? And what type of vasculitis is this? These are the questions we should ask when we come across a case of vasculitis. So 30-year-old male, he came with complaints of multiple palpable purpura or bilateral legs, thighs and forearm for a duration of 5 days. History of low-grade fever for 3 days, with the history of joint pain and neuralgia as well. No history of abdominal pain, vomiting, melena. No history of hematuria or decreased urine output. No history of hemoptysis, dyspnea, chest pain, headache, and administration. No history of any drug intake, loss of weight, or loss of appetite. No no history of limb claudication, loss of sensation, no history of asthma, hypertension, no history suggestive of connective tissue disease, no history of any focus. On investigations, CBC hemoglobin was 11 gram per deciliter. Total counts were 12,300. Platelets were 2.5 lakh. Blood culture sensitivity was sterile. RFT, LFT was normal. ESR and CRP was 46. And the urine analysis, stool occult blood, 24-hour urinary protein was negative. Then chest X-ray, ECG were normal, and biopsy was suggestive of leukocyte plastic vasculitis. This was the biopsy report of the patient. We can see that there is moderate perivascular period nuptial infiltrates of neurofilaments. Dermal blood vessels will show transmural. There is extravasation of RBCs, and on immunofluorescence there is IgG and C3 are present in trace in dermal blood vessels, and IgA is 1 plus in dermal blood vessels. So it is suggestive of leukocytoplastic vasculitis. So since IgA was also positive in this case, HSP can also be completely ruled out there. So what are the differentials here? Cutaneous small vessel vasculitis as well as IgA vasculitis. That is HSP. So treatment will be ibuprofen, taps on topical steroids.